So without further ado, my task was assigned to address whether routine molecular testing should be performed in CLL. And I want to stress that this is to address the fact that most of our patients are treated in the community setting and not at academic centers. So I'll start with a case of a 72-year-old male who presents with isolated lymphocytosis and is identified with CLL, right, stage 0, asymptomatic. And because of the absence of symptoms, it's recommended that he undergo surveillance. No molecular testing is performed, and after 8 years of clinical surveillance, he has a stable course and dies of unrelated causes. So that's not very exciting. The second case across town is another 72-year-old male, also with newly diagnosed asymptomatic early stage CLL. At the time of diagnosis, he undergoes additional advanced molecular testing with a multi-probe FISH panel, as well as assessment of IGHV mutation status. And the results of the testing show what statistically would be probably the most common result, which is deletion of 13q. He has a mutated IGHV, and he also undergoes active surveillance. However, over the subsequent year, he develops clinically appreciable adenopathy, fatigue, and this prompts initiation of therapy after 2 years. And let's just say hypothetically that at the time of initiation therapy, he's identified as having a point mutation in SF3B1. So there are a lot of benefits to molecular testing, but what are the costs? So at most of our centers, the list price of the VISIS FISH panel from Abbott Diagnostics is $1,500. IGHV mutation is comparable. So if there are 15,000 cases in the US each year, this is about $45 million to the healthcare system. As many as 30% of patients will never require therapy. Now, you could say we won't know which ones those are without testing, but of course we don't know exactly which those patients are with testing either. As was illustrated at the noon conference yesterday, and again by Dr. Jones, 17P at the time of diagnosis is uncommon and does not mandate initiation of therapy in the absence of symptoms. And given that the median time from treatment from diagnosis to treatment is in excess of 6 years, repeat testing at the time of initiation of therapy is probably appropriate to rule out clonal evolution, so it's often performed. This matters because we should be stewards of our resources in this country as the thought leaders in the room mandate or make recommendations for what testing should be done. So this is healthcare costs in the United States, and this matters because the NIH funding has gone down over the past 10 years. So if those are the costs, what are the benefits? I think there's sort of two things to address. One is the prognostic implications, and we'll address what is the value of these prognostic data. But I think the more important point is the predictive value of these tests. So in what circumstances do the results of these tests actually lead to actionable items that will guide our choice of specific therapy? I don't want to belabor these points, but we all know for the past 15 years that cytogenetics affect overall survival as well as time to initiation of therapy. IGHV mutation status separates patients based on overall survival and distinguishes two major subgroups based on biologic differences. And of course, these can be stratified with rough surrogates based on CD38 and ZAP70. Of course, the results of testing for these markers by flow cytometry is variable depending on cutoffs and reference laboratory. So you can predict for a group of patients based on the size of the lymph node and the LDH value as stratified by IGHV mutation, and then the number of lymph nodes, and then the presence or absence of high-risk cytogenetics, what the point value will be, and then using the MD Anderson nomogram, you can give a patient or a group of patients a statistical treatment-free probability. Of course, these won't influence what you do at the bedside, but are probably more useful as clinical tools. And as you'll see, these probably need further refinement as we get more prognostic information from additional molecular tests. So on that topic, we know, and most don't need to remind most of the members of the audience here, that the FISH probes assess for a sequence of DNA, which will be either present or absent under fluorescence microscopy. But if you have a point mutation, you will not detect this by FISH panel, and so you need to directly sequence it. There are many FISH point mutations that have been identified in CLL over the past 2 to 3 years, P53 being most well known, but of course Notch1, SF3B1, Burke, and MIghty88 have been mentioned during this conference. Notch1 occurs in about 10% of cases. There's a hotspot on the C-terminal PES domain, which renders the protein resistant to cleavage by gamma secretase and results in constitutive activation. Based on the MLL consortium data, Notch1 is present in a significant number of patients at the time of diagnosis, probably somewhere around 10%, as I said, and it does influence time to initiation of therapy, as well as overall survival. Interestingly, there seems to have enrichment in the trisomy 12 cases, and likewise in these subgroups, these cohorts, presence of Notch1 mutation confers more rapid time to initiation of therapy, although it does not influence overall survival. SF3B1 has multiple hotspots for mutation. The biologic implications of these mutations are not as clearly defined, but clearly result in aberrant, most likely result in aberrant RNA splicing. SF3B1 mutation at the time of diagnosis confers decreased time to initiation of therapy, decreased overall survival, and in the 13q subgroup, as suggested by the second case I showed, will show a much more rapid time to initiation of therapy, as well as overall survival. So those are sort of the major prognostic tests we have. So let's move to predictive values or tests. So it's been known for a long time that 11q, this is the CLL4 study from the UK that showed 11q patients when treated with either chlorambucil, fludarabine, or FC, fludarabine cyclophosphamide, I should clarify, had inferior survival, PFS, but when you looked at those who received cyclophosphamide and fludarabine, the combination seemed to overcome this poor risk cytogenetic finding. 11q is probably also overcome by addition of rituximab, as shown by the green line in PFS from the German CLL8 study. And again, in the bendamustine rituximab, if you look at from the phase 2 data, overall response rates and PFS is comparable in the 11q group compared to the overall population. So continuing with the CLL8 data, we know it's very well known to everyone in the audience that if you look at P53 mutations shown in the blue lines when treated with FC or FCR have significantly decreased PFS relative to P53 wild type. In addition, SF3B1 point mutations, as shown in the blue lines when treated with FC or FCR, have significantly decreased progression-free survival relative to SF3B1 wild type. But there was really no differential effect. What I thought was very intriguing by this retrospective analysis was the effect of Notch1 mutation on chemoimmunotherapy treated patients. Here, the Notch1 mutations, the blue dashed and the blue solid lines are superimposable, suggesting that addition of rituximab does not benefit patients with Notch1 mutations. And there's a couple of other lines of evidence to suggest that. This is a smaller study from the UK of patients treated with induction fludarabine followed by consolidation rituximab. And Notch1 mutation, again, was found to be associated with trisomy 12. and inferior progression-free survival in the induction phase. And then if you looked at the consolidation phase with rituximab, granted they're small numbers, the solid line here shows the patients with Notch1 mutation didn't have improvement in PFS when consolidated with rituximab. When we look at the newer monoclonal antibodies against CD20 from the complement study of chlorambucil versus chlorambucil ofatumumab, there was at ASH a retrospective analysis looking at Notch1 mutation, wild type, and Notch1 mutant cases. It was found in 12%, evenly matched in both arms, again associated with trisomy 12. The mutation did not affect PFS when treated with chlorambucil, but shorter PFS was found in the, if you look at the red line here compared to the black line, presence of Notch1 mutation conferred inferior PFS. And this was identified in multivariate analysis. Going back to the future, I guess, might be, I don't think this will be sufficient to resurrect alemtuzumab for the grade, but there was some signal that Notch1 mutation actually has preferential activity or benefit from alemtuzumab. So in summary, we'll get in under the 15 minutes. So cytogenetics molecular testing is obviously validated in large groups of patients and highly valuable, particularly for clinical research. More precise prognostication of individual patients probably would require assessing for point mutations in addition to the large deletions by FISH. And so the clinical value of routine baseline testing is highly questionable, given the high cost of treatment, the number of patients never requiring therapy, and the long latency of from diagnosis to treatment. Regarding the predictive value of molecular testing, currently 17p is the most actionable result. 11q probably should receive either bendamustine or FCR. The predictive value of Notch mutation is sort of provocative, and this will require validation in the newer with obinutuzumab. And the impact of all these mutations is going to require further study in the area of novel agents. So for the final slide of the, I'll be provocative and see if I get any tomatoes thrown at me during the question session, but I would say that a proposed recommendation should be ZAP70 CD38 testing is reasonable because it can be incorporated into diagnostic flow cytometry panels without significant cost. But really, in the routine community setting, there's really very difficult to come up with a scenario in which on FISH and IgVH mutations should be routinely performed at the time of initial diagnosis in the absence of a clinical indication for treatment. When treatment is indicated, determination of 17p and 11q is very reasonable, and additional study will be needed for alternatives to monoclonal antibody treatment in Notch1 mutation treated patients. And with that, I'll thank you for your attention.